Hello, this is Dr. Mintz. This is an MRI lumbar spine. It's a T2 weighted sequence. You can see the CSF is bright, and the conus medullaris usually ends at about the T12L1 level, which would be at about this level. This one looks like it's ending at about L1, L2 here. And this does look like it's the conus medullaris right here. Here's some bunching up of the nerve roots because of the severe central canal stenosis present at a couple of the lower levels. So here you have L3-4, L4-5, and L5-S1, and there's severe disc degeneration at all three of these levels. There's loss of the disc space height, one of the indicators of disc degeneration, as opposed to the more normal discs here at T12, L1, and L1/L2, where we have hydration of the disc with somewhat increased signal intensity on these T2 weighted images. The vertebra appear intact at these levels, whereas at these levels we have really substantial endplate changes, degenerative endplate changes at L3-4, L4-5, and L5-S1, with just a little bit of fluid signal intensity in the disc space that reflects the severity of the disc degeneration that has occurred in this area. So all of this I would group together as degenerative disc disease severe, and along with that there is anterior osteophytic spurring. You can see how the bones, the vertebra, are contributing to these anterior prominences that are bridging partially between here the L4 and L5 vertebra. So these are anterior osteophytic spurs. Here you can see at L3-4 there is bridging osteophytes that are bridging this distance between the L3 and L4 vertebral bodies with severe narrowing of the disc space height. There's also some posterior osteophytic spurring at these same levels. Here's posterior osteophytic spurring at L3-4, a little bit at L4-5 and L5-S1. Some of this low signal is osteophytic spurring. Some of it could be some degenerative disc as well. Here's a very mild early degenerative disc showing loss of the normal intervertebral disc signal, which we see more normally here and here, and you see a little bit of a excrescence of disc tissue that's pushing posteriorly and undermining the posterior longitudinal ligament. Posterior longitudinal ligament extends over the posterior aspect of the vertebral bodies and extends also over the intervertebral discs. So in order for a disc to really herniate downward, it has to undermine the intervertebral, it has to undermine the posterior longitudinal ligament and elevate it. And that's what we're seeing a little bit of right here. Okay, and these are all very severe disc degeneration changes. Here are the spinous processes from L2. Here's the spinous process of L3. There's some degenerative changes where the L3, L4, and L5 spinous processes have abutted one another and ground against one another, creating these degenerative changes in these spinous processes. You can also see that the facet joints, which here look fairly normal and here look normal. Let's see above that level. This is an even more normal appearing facet joint. These are a little bit hypertrophic, but these are very hypertrophic, and that's because when there's loss of disc space height, the facet joints take up more of the weight bearing and they accordingly hypertrophy from the abrasive forces at their interfaces with one another. So you have superior articular facet, inferior articular facet interacting with one another, and when the disc itself is holding its own and keeping things at a proper distance, then you have a more normal facet joint. But when the disc space has collapsed and decreased that distance from one vertebral body to the next, then the facet joints end up bearing more of the weight than they are designed to accommodate, and they therefore hypertrophy. Now here you can see at the L2-3 level there's a disc with mild degeneration, as I noticed before, and over on this left side you have a nice neural foramen. You have fat around the nerve in the L2/L3 neural foramen, and you can see the nerve root quite well there, whereas you move down one level and you can see that things have tightened up a severe degree there. So here you can hardly see any fat around the disc. Here you can see hardly any fat in the neural foramen around the nerve root, and here would be the L3 vertebra. So at L3-4 we have the L3 nerve root exiting the L3-4 neural foramen, going under and out under the pedicle and then out laterally. So this is severely narrowed, and part of that is from hypertrophy and degenerative changes at the joint of Luschka, this articulation between the actual edges of portions of the vertebral bodies, and often the facet joint also becomes hypertrophic, and that encroaches upon that neural foramen as well here, only a mild degree in this case. Now here's a better depiction of that anatomy, showing a nerve root in the neural foramen, and you have a little bit of fat still around the nerve root. You have this narrow disc space at L4-5, which is causing osteophytic spurring to Here you're finding this neural foramen narrowed partially by this hypertrophic joint of Luschka, which is narrowing the neural foramen here on the left at L4-5. But you also have some facet joint hypertrophy causing this little prominence here. So together they are narrowing a large portion of the neural foramen at this level at L4-5. Let's go over to the other side. Here you see a little disc herniation, small amount of disc actually not just bulging but herniating superiorly along the posterior margin of L4. Now this is the posterior longitudinal ligament, and it is relatively elevated by the osteophytic spurs posteriorly at L3-4 and L4-5, kind of lifting it away from the back of the vertebral body, and that contributes to narrowing of the central canal. And you can have pressure on a nerve causing symptoms. You can have narrowing of neural foramen causing pressure on the nerve, causing symptoms. And you can also have central canal stenosis, narrowing of the overall diameter of this tubular structure, the spinal canal, which contains these nerve roots, which are collectively referred to as cauda equina, horse's tail. So the cauda equina is a bunch of nerve roots going through the spinal canal here, and it can get narrowed due to things like this elevation of the posterior longitudinal ligament and posterior prominence and osteophytic spurring arising from the posterior elements, as well as some facet joint hypertrophy occurring on both sides, narrowing the posterior lateral aspects of the spinal canal. Here we have a CT of the same showing a correlation between the CT and MRI, and here you can see what those scraggly looking end plates at L3-4 and L4-5 are. There's been a laminectomy performed at L4, and a laminectomy entails not just the lamina will be this part, but also and this part, but also the spinous process typically comes off with a complete laminectomy, and this was a complete laminectomy at L4-5, or rather at L4, probably for problems occurring at the L4-5 level. And severe disc degeneration at L3-4 and L4-5 and L5-S1, but pretty good preservation of disc space height at L2-3. Here's an MRI again showing the severe degenerative end plate changes. This is a T1 weighted sequence. So we're getting a little bright signal in the vertebral body related to the fat in the marrow, but that's obliterated by the severe degenerative disc disease and end plate changes at the inferior L3 level and superior and inferior L4 levels, and to a lesser extent the superior and inferior L5 levels. You can see that there has been a laminectomy here at L4, and a portion, looks like just a portion of the spinous process has been taken out at L4, and there's a little bit left of it right here. But this vertebral body has more substance than you might think because it's edematous, it's sclerotic. So the high signal that we ordinarily attribute to vertebral bodies is largely lost here, and it blends in with the associated fibrous tissue and bulging disc, and so it's hard to discriminate where the actual vertebral body is here. But this is intervertebral disc, this is the inferior end plate of L4, this is superior end plate of L4, and this is the height, this is the whole vertebral body in this area right here. There's actually some degenerative changes also at L5-S1 with this edema, primarily edema at this point, due to that disc space narrowing and the abnormal abrasion forces of the inferior end plate of L5 and the superior end plate of S1. Here's another more T2 weighted sequence showing you more clearly the edema associated with the end plates and the profound irregularity of this L4 vertebral body due to the degenerative changes. But here at least you can see the maintenance of the overall general configuration of the L4 vertebral body as well as L3 and L5 vertebral bodies. This is deformed, but it's maintaining its articulation with L3 and L5, albeit with the production of considerable central canal stenosis here. at L4-5, and significant also on the other side here at L3-4. All right, let's go on to an axial to look at that. So here we have the sacrum and the iliac bones. That makes this the sacroiliac joint. Sacroiliac joint. Here are the sacral neural foramina with the sacral nerves in the sacral neural foramina, and here's a little bit of the thecal sac, the spinal canal, extending down all the way inferiorly toward the end of the spinal canal in the sacrum. Here you can see that irregularity of the L4-5 or 3-4 level. That looks like this is L4-5, so that's L3-4. You see the protrusion and hypertrophy of this aspect of the disc space and adjacent vertebral end plates at the L4-5 level. You can see how there's central canal stenosis due to posterior osteophytic spurring here, and hypertrophic changes of the right facet joint at this level as well. You can see the facet joints themselves here up higher. I think that's 3-4. Look quite hypertrophied. So they should be really limited to this area here, but they're curving around kind of like a telephone receiver here. And here we are at about L2-3, and this looks much more normal, with even a hint of a little bit of fluid in the facet joints. These are the psoas muscles. Here you have the aorta and IVC. Here it is with IV contrast, gadolinium administered. You can see the venous structures in the vertebral body enhancing. And you can also see that there are enhancing areas of the vertebral end plates that suggest an inflammatory process. And in this patient, I think this is a residual infectious process, which may still be infectious, or it may be just granulation tissue and some areas of residual inflammation without actual organisms. This does demonstrate the neural foramen nicely. There at L3-4, and here you can see the narrowing at L4-5, and here's a neural foramen at L5-S1. It's kind of hard to see, but here is L3, so this is L3-4 interspace, so this is the L3 nerve root, that's the L2 nerve root. They're in kind of a keyhole shape, a classic keyhole shape, and so when you see that fat starting to get obliterated like it is here, you know that there's increasing pressure on the nerve root, and sometimes you can see that the neural foramen is sufficiently obliterated that there is unlikely to be any normal configuration of the nerve root within that neural foramen, and that it's largely effaced and deformed by the encroachment upon the neural foramen by the adjacent bony and cartilaginous structures. Shows you how nicely the IV contrast enhanced studies can be at depicting a lot of the anatomy here. And it also shows you that if you go through it from right to left and you pay attention here to the central canal, to the left, to the right, to the left, you see that there's far less area, cross-sectional area in these regions at 3, 4, and 4, 5 than there are, let's say, at these higher levels up here, much more. And so this is central canal stenosis, and that has specific sets of typical symptoms, and it can include bilateral lower leg pain. But you can see very clearly here a dramatic demonstration of central canal stenosis due to L3-4 and L4-5 disc degeneration, inflammatory changes that probably reflect an earlier infection, and a narrowed canal that is considerably smaller, even at its maximum, compared with the more normal upper lumbar spine. Here's a coronal image. Shows an incidental large cyst of the left kidney and an incidental cyst also of the liver with some septations. And here you can see the spinal cord coursing in the spinal canal in the thoracic spine. Here it is, and because it has the curvature that we're so familiar with, convex posteriorly at the thoracic level and concave posteriorly at the lumbar level. Here you can see how there's been an asymmetry in the loss of height of the L4 vertebral body, more loss on the right than left, and that has allowed this L3 vertebral body to attain this tilted configuration, which just adds to the equation of compromise of neural foramen and central canal. And more of the same. Here again is that here's the conus right here. You can kind of make out that this is cord here, and that somewhere here it transitions to a bunch of nerve roots. And this is unusual for the nerve roots to be kind of clumped together in this fashion due to, I presume, the central canal stenosis below that won't let the nerves slide smoothly up and down as the patient bends forward and backward. Neuroforaminal narrowing. Severe neuroforaminal narrowing here and here. Mild to moderate neuroforaminal narrowing here, also with facet joint hypertrophy. Look at this happy little facet here. Little or no hypertrophy. And then you look at these craggly old things here like this. That's blooming and expanding to compromise the neural foramen. This is a T1 weighted image without IV contrast, and it shows how much contrast can help with delineation of anatomy on T1 weighted images, which otherwise it's very hard to distinguish one thing from the next. But if you look closely, you can see a margin of what looks like this degenerated disc where it directly abuts the marrow substance of the vertebral bodies above and below. Same kind of thing, same patient, just different sequences. Narrow neural foramen there. You see how tight that is. And all of these sequences have different advantages and disadvantages, but collectively they contribute to an overall picture of what's going on and which are the most severe levels to be considered for surgical interventions if the symptoms warrant. Okay, here's with some IV contrast delineating these structures pretty well. Here you can see a fat suppression sequence with low signal in most of the vertebral marrow, but markedly increased signal throughout the substance of L3, 4, and 5, indicating an inflammatory process. It could be active inflammation. The clinical signs and symptoms would be necessary to rule that in, but this, I think, is an aftermath of an infectious process. And you can see how much granulation tissue and enhancement there is in the spinal canal and around the central canal and the cauda equina, the distal spinal canal at these lower levels. Psoas muscles, vertebral body, transverse process, spinous process. Here, facet joint. The spinous process is the bumps that you feel over your back as you run your fingers down your back or someone else's. This is showing all the nerve roots, the cauda equina seen cross-sectionally at this lumbar level. And you can see each of the individual nerve roots pretty well, and you can also see how this cauda equina, this central canal, this spinal canal, is easily compromised by facet joint hypertrophy from either or both of these facet joints. More lumbar levels showing fluid in the spinal defect from the prior surgery and a seroma that is accumulated fluid in the subcutaneous tissues of this area. In fact, I think this is a post-operative area from prior surgery about a month before this, and this patient got a spinal infection and spinal abscess. So what we have here is this area of where the surgery was done, and they went in and did a laminotomy. They went in and did a laminotomy here, and an infection developed in the bone and subcutaneous tissues, and so this actually is all abscess. So that's a pretty severe, serious complication from surgery. Fortunately, it's rare. Here again you see L3, L4, L5 with the endplate degenerative changes. Here you have a T1 weighted image that is not as graphic in its depiction of the abscess, but it's still here, low attenuation. And here you have again that fluid collection that's extending between the spinous processes, including the inferior aspect of the L3 spinous process here, and the remnant of the L4 spinous process here that is due to the prior surgery. And here's as good a picture as you can get of this being the defect of the partial laminectomy that was done at the L4 level, where fluid accumulated and subsequently communicated with the subcutaneous space here where the surgical incision had been performed and the laminectomy performed in the same procedure here, and you have what turns out to be pus communicating between these two compartments. Then always good to look at our regular radiographs, and you see, although these end plates look very compromised and somewhat degenerative, they don't begin to look nearly as abnormal as you can see on the MRI. Neural foramen, neural foramen, neural foramen here. And that's about it.